Well, welcome everyone to today's webinar. We are co-hosting this with Sanford Behavioral Health. I'm Kristen Taylor. I'm with MHAM, also known as the Mental Health Association in Michigan. I am their Director of Community Outreach and Education, and we're so happy that you're here today. Today we're going to be talking about the brain, understanding the neurobiology of substance use disorder. And our two presenters are Rae Green, she is the founder and president, and then we have Carli Noffsinger. I hope I said that okay, Carli.
You did great.
Thank you. So Rae is the founder and president of Sanford Behavioral Health. Rae's unwavering dedication to mental health advocacy has profoundly impacted individuals and families. Her tireless events have transformed countless lives, bringing hope and healing to those affected by addiction and mental illness. Through her dynamic presentations, community engagement, and educational initiatives, Rae strives to reduce stigma, empower individuals and families, and foster a culture that embraces the importance of behavioral health. Rae says, "Life stories inspire me, and I am propelled to continually strive for a standard of excellence within the treatment world. I am privileged to commit myself and my resources to this specialty." So welcome, Rae.
Thank you.
With us is also Ms. Carli, and she has worked as a social worker and therapist in mental health, addictive disease, and co-occurring disorders. Upon retirement, Carli joined Sanford Behavioral Health on a part-time basis and has worked with client family members in their family education and support programs. She has a master's in social work, is an LMSW, and writes for Excursions, the behavioral health online magazine. Welcome to both of you. Thank you for being here. You guys have graciously been part of an educational series with MHAM for the past year, so we thank you for your partnership with that.
Thanks for including
as well,
us.
if you are here, as well as you're here as a guest, if you need CE, please drop your full name into the chat, and please state which type of CE that you are here for. And with that being said, Rae, go ahead, take it away with Carli. You guys are going to do some kind of dialogue, some questions back and forth, and then we do have a PowerPoint here. So, just tell me how you want this to roll.
This dialogue between Carli and I and the PowerPoint pictures, this is a distillation of neurobiological information that I provide to our clients. So I do the neurobiology group so that they can comprehend and understand at a pretty basic level what's going on with their brain and their body. I'm not a medical background person, but I do often have a nurse or a psychiatrist, sit in and just audit and make sure that the information that I'm giving you is still current and accurate. So while it is simplified, I do have other eyeballs on it. So with that said, I think we're going to start with Carli providing a definition of addiction.
Okay. This is a definition that Dr. Nora Volkoff from NIDA, excuse me, has put together. And I just think it's fantastic. She says, addiction is a chronic relapsing brain disorder that results in compulsive drug use that continues despite negative consequences. And a little bit of addition here. When you're in practice with folks and you see people that report they're having loss of control over their use of their substance, and they say that no consequences, nothing can make me stop. And they tell you that they have this compulsion to use and that they have cravings. You're dealing with someone that has addictive disease. And one of Dr. Volkoff's partners that she's done research with, Dr. Anya Jordan from Yale, also says, when she's talking about addiction, and she added this to Dr. Volkoff's information, she said that addiction requires repeated exposure, deep memory impact happens, and that drives the intense desire to use. And she also adds that the largest risk factor for developing addictive disease is genetic history. And we instruct in our family program, we talk about addictive disease is a biopsychosocial disease, and there is that genetic component. And as Rae said, she does the group for residential and outpatient and talks about how addiction is a brain disease. We also have a whole section in our family education program that discusses how the brain is impacted by addictive disease. And as we go further in this presentation, we'll talk about then how that affects families.
So I will launch into this report, which is, oh, Kristen's starting. All right, our disease-based model. Okay, you can go to the next one. So I'm just going to tell you about this. We're not going to play the song. This is Smokey Robinson and the Miracles, You Got a Hold on Me. And I encourage you to listen to the lyrics of that song. Go ahead and go to the next one before our song starts, Kristen. Okay, so that guy on the screen, Dr. Vivek Murphy, he headed up this big fat volume, the Surgeon General's report in 2016. And I know that seems like a long time ago. And so I thought that as well. And I looked up, there's got to be studies on how this report has impacted what we know and what people have learned, how has it changed the landscape of use and addiction. And there's nothing, there are no studies out there on what impact this had. So I keep the pulse on that to see there's got to be some being done. But anyway, what was the purpose of this report, and there were three. You can get this report for free if you want to order it from the government, but it's big and fat and a little boring. So I'm going to just dissect out the three main points. And the first one is this quote from Dr. Murphy himself. You know, we need to treat substance use disorders the way we treat any other chronic illness, with skill, with compassion, and with urgency. And, you know, in that, his intent was to legitimize the disease-based theory. You know, saying that, you know, like heart disease or diabetes, that it requires lifelong maintenance. But, you know, that you can recover. And so this was a big statement about taking the perception of the disease as a character defect, of flaw, decision, and it said, no, we're dealing with a disease. It also, I think, spoke to insurance companies to say, you know, we're dealing with a chronic progressive illness, and so nudging it more into the area of science. So that was the first part of this report, and the second chapter really studied the brain research, and it studied the neurobiological processes that turn casual use into compulsive use. And that goes along with what Carli's definition was. So going from casual use to compulsive use. But that brings me to the second extraction that I took from this big fat report. And that is that there are 40 million people in our country who have not reached that top 1 in 10 people who struggle with chronic progressive disease, 40 million people who are in that category of misuse. And the report spent a lot of time talking about misuse because we learned from the Surgeon General's report in 1968 on smoking that to 2015, smoking was reduced by 65%. And that was just awareness and knowledge. So the fact that people who were, you know, misusing could make the choice, well, there still was the ability to make the choice. And that's the idea behind misuse and the concept in this report. So that's really speaks to the hope for the future of getting people to accept treatment earlier, and then of course the rates of success skyrocket. And then finally, in this report, 2016, 9 years ago, this Surgeon General stated that medication-assisted treatment is a gold standard of treatment. Now, we may take that for granted now. Any of you in this field, professionals in this field, I don't know what backgrounds are out there, so I'm giving an array of information that you may already know. But what that said was, if we're going to treat this like a disease, then let's use the medications that support the healing of this disease. Again, nudging it more into that category of science. And there historically has been some resistance to that use of medications. And so, particularly with the opiate crisis, we know that medication is critical to saving lives. So that was kind of a big statement that he made as well. All right, so I'm going to set my big volume aside here. That's akin to any of you that are my age that remember the phone book. You know, when you say get the phone book out, and the kids can sit on the phone book and they can reach the table. That's kind of what his report was. So again, the intent was to shift the way our society thinks about addiction and substance use disorders. And that was this. All right, we can go to the next slide. Whenever I see him on, he'll often he's written a lot of books, and he'll do things on CNN and that. And I come kind of a groupie of his. Yeah, I'm kind of a groupie of his. So here's some statistics. The bottom one, less than 20% of those who need treatment receive it. And we know that is really connected to societal stigma, that people don't seek treatment for that reason. The 10% of medical schools teaching addiction, that statistic has not changed since 2015 when I started working on this amount of information. So those are some things that we as an industry really need to work on changing. Okay, next slide. I'm talking fast because I usually take longer than 45 to 50 minutes to do this, and we want to leave some time. Okay, so this is the hardcore part of disease-based model.
Yeah.
So you've got these. I threw in the amygdala. That's a little extra. And I'll tell you why that's important too. But you've got that midbrain, and that midbrain is that primal part of the brain. And so I tell my clients, think of that as the caveman part of the brain. And that caveman part of the brain was responsible for us as humans as we evolved. And that told us to eat, sleep, procreate, all of those compulsive behaviors that allowed us to survive. And when we do those behaviors, it sends a little message over there to that nucleus accumbens, and that's the reinforcement center, the reward reinforcement center. You guys will probably remember Pavlov's dogs and the ringing of the bell and the salivating. I mean, that's all that auto reaction through the nucleus accumbens, a set of glands that's our reward reinforcement center. As we evolved as humans, we got this nice handy little prefrontal cortex, our higher level of thinking that distinguishes us from other animals on the planet. It tells us to be conscientious. It guides us in our relational abilities, that higher level of thinking. And so those are the three main parts of the brain that are impacted by the disease of addiction. Here's what happens in a nutshell. The addictive substance, drugs or alcohol, cross the blood-brain barrier, and they land in that caveman midbrain. And then that caveman midbrain sends up a message to the nucleus accumbens and says, wow, this is fun. This feels good. Like, do it again. But then we have our executive director, prefrontal cortex, and the executive director says, you know what? You've had enough. It's closing time, it's last call, maybe you should take an Uber or a cab. And so that system is somewhat balanced, right? It's working in, I guess, what we would refer to as a normal, I use air quotes on that, a normal use. But here's the progression of the disease. That neurobiological highway of substance that passes through the blood-brain barrier and hits our caveman midbrain, that message, as use continues, And then you throw in the things that you mentioned, that memory,
frequency, intensity.
and DNA, genetics.
Yes.
All of that can guide and tell us how fast we build that neurobiological highway, how fast the highway's built and how fast we go on that highway. And so it really changes the neurobiological components of the brain. And then that message from caveman gets stronger and louder, and it starts yelling at the nucleus accumbens, do it again, do it again, do it again. And the nucleus accumbens kind of evolves into a frat house. It's out of control, and it is seeking more and more, and it wants more of the substance, and that message is getting stronger. But what happens is during this process, the executive director, that prefrontal cortex, starts to go to sleep. And this is all dopamine driven stuff. This is dopamine rewards, and then dopamine is also an anti-reward, which is what guides the prefrontal cortex. But that starts to go to sleep. So as the disease progresses and chronic progressed state, where casual use has now stepped over that line and turned into compulsive use, is because the caveman is large and in charge, sitting in the driver's seat, executive director, sleep at the wheel, and the message is being sent to the nucleus accumbens, to the now frat house, is as strong as the will to survive. So the compulsion to use actually becomes a compulsion that equals the will to survive. And I tell my clients, if you don't remember anything else from this lecture, they usually remember the Smokey Robinson song because it's so good and it stays in your mind. They remember that this use isn't a choice. Nancy Reagan's Just Say No campaign, which give her a lot of credit for that. That's why it didn't work. That this isn't a just say no. This becomes compulsive and driven by caveman compulsion. So I want to go to the next slide, but at some point, Ramon, you remind me about the amygdala, because I want to talk about that, but I want to go to the next slide.
Okay.
So we're going back to Dr. Volkoff, and she, again, is one of the foremost researchers in the world. And she wrote this article in 2015, which was a year before the Surgeon General's report. I will encourage you to read along with me. The ensemble of brain changes, which we just talked about in that caveman, can be likened to a broken video game. The addicted person's world is like a threatening virtual environment and landscape, calculated to pose maximal threats to sobriety. Around every corner and lurking every shadow are drugs and drug cues, yet the person playing this game must navigate with a broken controller. That is the sleeping executive director. So somebody leaves our residential treatment and they look fabulous, and they look healthy, and they look like themselves, but that broken controller is still healing. And so they go home into this threatening environment and they're operating with a broken controller. And that is the process of early recovery. That's what we talk about when it's post-acute withdrawal. Those are all the symptoms of that healing process. Okay, amygdala. You see that drugs and drug cues? What the amygdala is, this is Ray's version of the amygdala. And the amygdala, like a treasure trove of memories. And that amygdala attaches emotions to those memories. And so if you pull into your drugstore where you used to buy your wine, that amygdala is going to flash technicolor memories into your brain, which are the threats that Dr. Volkoff is referring to. And so that's where the amygdala plays a little role. Okay, I've done all this talking, and I want to let Carli say some things before we go to our next slide. You got anything to add? I'm kind of hogging the mic here, which
that's okay.
My husband says I do, so.
He's right.
He is right, I know.
But anyway, folks, as a person is developing addictive disease and they're going from that misuse, okay, into developing the compulsion to use, what we're seeing is in the family has long, even before this started to happen, unfortunately, the family feels like they have to protect their loved one from this problem that they seem to be having, and also protect others in the family from the consequences of the problem that the identified member of the family is having. And as we move from, gee, I think I can help if I do this, I'll try this, I'll try that. As a person moves from that role of thinking that they can help solve the problem, the disease continues to progress. As that disease progresses, we see there is no longer choice over to use or not use. And we see that what we call enabling behaviors, and I know everybody knows a lot about codependency, codependent type behaviors escalate. And as the disease progresses, the codependency gets a little bit worse also. And we were working on some things for family program a few weeks ago, and I was going over information, and all of a sudden it just hit me like a brick. We as clinicians, when we're working with people, it's so hard to get folks that are family members to understand that sometimes help isn't helpful. And in the case of addictive disease, we need to get them to understand that this is a brain disease and it's progressing on its own. And you have to learn how to make choices that actually do not help the disease to progress.
The family does, right?
Yes.
Yeah, the family does. Yep.
Right. And the family is so into trying to control and change the person's behavior. Okay. And all of a sudden it hit me. It was like, oh my goodness, when we have addictive disease, we're dealing with obviously a compulsion to survive. I have to use to survive versus some very, early kind of attachment and bonding kinds of experiences in human beings. So the family is dealing with, I love this person, I'm committed to this person, I want to protect this person, and they're coming at it from their perspective of, I have to fix this, I have to fix this. And the person that's developing addictive disease is, I got to run away. And so what we're dealing with when we deal with family members and people that have addictive disease is the fact that we have opposing instinctual drives that are going on. And I just think we have to educate our families on the disease and educate them more on, how to be strategic with this disease, and real clearly, how difficult it's going to be for the family to make behavior changes. Because a key here in the recovery for someone with addictive disease is that their family becomes a support system instead of a system that's pushing on them to change. And my goal here when I work with our families is to have them create a recovery-friendly family environment. And that can't happen when we have all this head knocking going on. So I just think that that's an important piece to keep in mind.
I'm sorry, I got distracted because there's a really pretty spring bird out the window, you guys, yay. But would you say, is it safe to say that when I think of this helping and protecting, evolving into enabling, that codependency, that word that I think is an overused sort of word these days. It's kind of like the frog in the hot water. It can be in the hot water, but it doesn't feel when it starts boiling, right? That's so you start by helping, and it's hard to discern for the family to know when that transforms or evolves into an enabling behavior that is no longer healthy. And so that's why with the family, to help them recognize that that actually the protective behavior has been protecting the disease. And
Exactly.
so, but you don't really know that that's, as a family member, can't recognize that that's happening.
Right. Couple of things. One thing is, the more we protect people that are developing addictive disease from feeling the real consequences of their behavior, the more likely they are to continue that behavior. And you know that for yourself. As human beings, we will not stop something that we've been told is harmful to us unless we feel the consequences. In the case of addictive disease, for quite a while, the family's feeling the consequences. So that's an important thing to keep in mind. And as that desire to fix and control moves forward along with the progression of the disease, family members don't even see themselves sliding into the fact that, oh my gosh, all I'm doing is thinking about them.
Thank you. Next slide here. This is, so this slide was done by a scientist out of Pennsylvania. And he lost a son to an overdose, Dr. McClelland out of Pittsburgh, I think. But this is actual picture of a brain. So, you know, the things that we talk about, the changing of the neural pathways, we can now see thanks to modern science. And if you, the top picture with all the yellow on it, the brain with the yellow on it, that's the frontal cortex, the executive director in action. That's when it's full and operating normal levels. That second picture is after 10 days of abstinence. And so you can see that that frontal lobe is still healing. And the next one is after 100 days. And I don't know why they picked 100 instead of 90, because we always love the 90 and 90 and all of that. But 100 days, that's the, I guess, the one they took the picture. So that frontal lobe is still healing. And when I'm impressing the importance of this on to the people that we treat, they need to protect themselves, because when I had double knee replacement, the first thing people asked me was, how can I help you, right? What can I do? And I walked with a walker, and then I walked with a cane, and then I started walking slowly, but nobody asked me to run a marathon. You know, they said, how can I help? What can I do? Well, here, people leave treatment, and their friend, well-intended, says, you know, let's go to our favorite restaurant. And you just order a club soda or whatever the situation is. They don't understand, and nor should they don't have this background, that is like asking someone to run a marathon. And so helping clients, again, understand the neurobiological basis of this disease, that sleeping executive director, is so important when that healing process occurs. The question that I often get is, how long does it take? There's a 9-month saying that your brain really turns a pivot for the healing process at 9 months. Some people say a year. There's research that says 5 years, and I'm sure the longer someone is sober, you know, the healthier and healthier their brain gets. But 9 months is a more manageable timeline for people. One other, so I'm a history major as well, so I give a little tidbit here. The thing that I find myself fascinating about this is that 100 or 90 days, we see in these scientific pictures a change in the brain. Well, Dr. Bob and Bill W. knew at 90 days something happens with behavior, because they said 90 meetings in 90 days. Well, they didn't have, you know, the luxury of science and pictures, but they knew, and they observed it as well. So this drives home the point of healing takes time. And if we go back to that neurobiological pathway parallel, and say it's highways, well, we have an Autobahn going up to the caveman, and we're driving 90 miles an hour in a red Mercedes or whatever it is, and, you know, and it's fun and wonderful, and until it isn't. And that's when we usually see people. So that healing process, the journey of recovery, is that neural pathway, that highway shutting down, and the building of a new positive neuro pathway. And that's the work of recovery. So we take that a step further to the analogy of have you guys driven through a construction zone? You drive, remember Cascade Road under construction, and it was miserable. You had to stop and you had to go slow, and it wasn't pretty. And there were grumpy guys on the side of the road with their little flags telling you what to do and all that. And so it's not necessarily pleasant, but you endure it. You do what you need to do to get through that construction zone. And that is very much like an analogy to early recovery, because as that new highway, that new pathway is built, you start picking up speed, you get, grass on the side of the road. It's a prettier journey. Who was it? Johnson's wife, Lyndon Johnson's wife Lady Bird Johnson planted all those beautiful wildflowers on the side of the road. I mean, that's what starts happening with this healing. Okay, better look, 135. I guess we better go to the next one, Kristen. This one is just a message about social media. That in the old days, which were 20 years ago, there were TV commercials and that, but now in this day and age, there are websites and Instagrams you can follow that have millions of followers, and a lot of them are mommies at the park with their sippy cups. I just picked that one because I have women, and we talk a little bit about women and how it impacts their bodies faster and stronger than men, and so to beware of that pressure, because if you're not following or in that, you can kind of feel like you're not in the in crowd. And social media is driving that home. Okay, we could go on with that one for a long time, but go ahead and we're from Grand Rapids, right?
Right.
We can't
Yes,
not mention Betty Ford and all that she did. And Betty Ford did amazing things for forwarding the cause of substance use disorder. But what she represents is that this disease is non-discriminatory. She had the highest level enablers. That's called the Secret Service, helping her when she got off elevators so she didn't trip and things like that. This is all in her books. I'm not spilling confidentiality that Betty gave me, but she had the highest level enablers. So it tells us it's a very non-discriminatory disease. Okay, next slide. I know I'm talking fast because we're going to run out of time, Kristen.
It's all right.
This is just a reminder that words can be so impactful. And relapse, if you look it up in the dictionary, the words that define relapse are often like failure or, moving backwards and that kind of thing. So even the word itself can represent stigma, which is often stronger when someone relapses, don't you think, than when they first go into treatment?
Oh, absolutely. And I've got a statement here that I would really love to share with you from a gentleman that was in recovery for 4 years. And stigma is enormous with addictive disease. It blocks family members from feeling comfortable to go get help for themselves to deal with the problem. I have heard many people say, I just didn't dare go show up there. I didn't know who I'd see. I didn't want anybody to know. And, the fears of consequences of seeking treatment. Stigma does that to people. But I'd like you to listen to what this young man said. He'd been in recovery for 4 years. He was working at a treatment center and really being helpful and supportive with the folks getting past opiate addiction. And in conversation, he heard someone calling him an addict and said, well, that's so-and-so, he's an addict. And he says, when you call me an addict, you take away everything that is lovely about me. And something I want people to pay attention to is the language that we use. And before we end this discussion today, I'm going to show you some books and some resources that have to do with using appropriate communication and language with family members of folks that are involved with addictive disease. But language is huge. And when we just say, so-and-so, they're an addict, we don't say, that gentleman over there, that he's a remarkable artist and he's a really good accountant.
Mhm.
Oh, and he does have some addictive disease. We miss everything. We just see the dark and the gray and the black.
The are we making progress? Okay, go to the next one, Kristen. I got some pictures so the Science of Addiction 2017, that came out on that beautiful magazine, National Geographic. Remember all those glossy pages? Your grandma used to get them in the mail, and they were like looking a window into the world. And my husband and I were going through the Chicago O'Hare Airport, and this was on a stand outside of the bookstore, and I just got so excited. Oh my gosh, this is like, they're talking about it on the front cover of National Geographic, the oldest publication, 1888 in our country. He got a little embarrassed and told me to settle down. But anyway, that to me is progress. Now we see it on the the checkout counter at the grocery store. You see Time Magazine has done it and all that. All right. Couple other things here that I think suggest progress. This little Muppet, her mama is in treatment and she's in foster care. So Sesame Street is helping our children start to learn. The liver. There was a day when if you were in line for a liver transplant and someone else came and had cancer versus alcohol, they stepped in line ahead of you, and that is no longer legal. So if you are in line because of addictive disease and you need a new liver, you stay in line. All right, next one. We have so much to tell you, you guys. Kristen, can we just go till 3? No, I'm kidding. Uh-oh, did Kristen freeze? All right, I'm gonna keep
Anybody
keep
else
talking about
here,
a
Ray,
couple of.
or is she?
Let's go back to just that, what you were saying about family and the family helping them understand how to help their loved one maintain their disease and live with their disease. That they're also struggling with, how could my loved one do this to me? Right. So it's a complicated journey for those family members as well. It's not a disease known for its honesty, right? Or it's the behavior that accompanies the disease. And so you have a complicated intersection of emotions and healing going on. All right, so I can do this without the rest of the PowerPoint because a lot of what we have left is just reading some quotes. And I think,
Well, before you jump into
ahead.
that,
Yep.
can I share some information with
I would love
folks?
that.
Okay.
Yes.
So remember, I talked about language and how important language is. In the recent year or so, I've been introduced to a program called CRAFT, and I'm sure some of you have heard of it, Community Reinforcement and Family Training. And it's a method of dealing with family members to help them reduce their enabling of the disease and to also help them to learn a new way to communicate with their family member that has addictive disease. And the remarkable thing about CRAFT and the communication technique called PIUS, okay, is that it takes away the opportunity to enable, and it helps people. It gives them tools that they can use instead of going with their old approach to each other. And so here it is a book. I hope you can see this. This is called Getting Your Loved One Sober. This was written by Myers and Wolf. And this is for family members of folks that are dealing with addiction. And I've had people in my groups recommend it to each other. And it says, get your loved one sober. And it says, alternatives to nagging, pleading, and threatening.
I love that.
Yeah, it's just honest and good and effective. And then for those of you that are treating family members who have folks that are developing addictive disease in their family, this is what we call the CRAFT manual for treatment, and it's delightful. Okay, and it helps you kind of walk through this approach with people. And what craft does is it educates people about addictive disease, lets them know what the facts are and what does that mean to their behavior. Like that comment that Ray said about, how can you do that to me? Nobody's doing that to you. It's the result of loss of executive function and poor communication from the midbrain to the cerebral cortex. So I would like to just take a minute, if I could, and tell you about PIUS. And it's capital P, capital I, capital U, capital S. And I've used this with people in my groups and it works really well. The P stands for be positive. And for family members, because they feel this urgency to fix and that the fact that their loved one isn't available to them a lot of the time because of the addictive process, when they get together, it's highly conflictual. But instead of getting into the conflict, PIUS teaches people to take a negative thought, feeling, or situation and turn it into something positive. Quick example was I taught a woman who would just like overwhelm her son on the telephone when he finally called and checked in with her to say how he was doing and what was going on. And instead of overwhelming him with questions and why don't you call me more and da-da-da-da, I asked her to, why don't you say, I'm so glad you called. It's nice to hear from you. What's going on? You tell me about you for a bit and then I'll tell you about me. And eventually her anxiety reduced. Her son called more and they connected better. So it teaches people ways and statements that you can use and instruct them. Very helpful. The I is using I statements. We all know that working in mental health. But frequently in a home where there's addictive disease, there's a lot of defensiveness and blame and shame and guilt making. And we want to get that removed and deal with honest, open communication of, I really enjoy being around you when you're not using. We seem to have so much fun. Okay. Then the U part of it is understanding, demonstrating, the simple way of saying, I can't understand how come you would look at it that way. That makes sense. And I don't see it that way. So, we're going to have to ride this one back and forth with each other till we come to an answer. And then the S in PIUS is sharing responsibility. And many family members of people that have been, dealing with addictive disease are like ultimate kind of rigid controllers by the time their loved one comes to treatment, and they're not willing to say, yeah, I've made some mistakes about how I've handled this and I'm really sorry. So to share the responsibility for your part of the conflict and the disagreement. But one quick more thing I want to add. They have found, doing research on folks that are using the CRAFT and PIUS methods, that when they have treatment-resistant family members and they put the family around the person with addictive disease, they find that 74% more of those treatment-resistant people are likely to go into treatment and have success when they use this CRAFT model. So it's something that you can use while someone's trying to consider what to do. Also something that can be used as families move to reconnect after treatment
really
and
flows.
maintain
Right,
that
it flows
environment.
through the continuum of the disease. Kristen, I see that it's 1:49. Thank you for that beautiful family part. And we're ticking off, I think, the things that we wanted to talk about. I want to end with a quote. Do I have time for that, Kristen?
Absolutely, you have time. Apologies, my internet here at the hotel dropped, so I'm back on. But Yeah, you
Okay.
can, we can do a Q&A. If you have anything else you want to share, please do.
Okay, I have a couple things that I'd like to kind of do a wrap with. I will just brag a little on Carli, because she had orchestrated, designed, and ran our family group, and we would let the families stay as long as they wanted until they stayed for years. They were there for a couple of years, and so we had to nudge them out and make room for new members. And so our family group actually started a spin-off group. So it illustrates how urgent and important that family support and understanding of the disease-based model and the behaviors around supporting and not enabling. So Terence Gorski, the father of relapse prevention, my favorite quote out of his: recovery is like going up a down escalator. You can never stop. And that one resonates with the clients. Going up a down escalator, you can never stop. And that's the journey of recovery. Just as it is with diabetes or heart disease, you need to maintain a healthy lifestyle that respects the treatment of the disease. This disease is the only disease that heals with love. Right? We've talked about families.
Yeah.
We've talked about understanding of your body, which hopefully it generates some self-compassion for those who are feeling shameful and upset with, why did I do this? And so I want to wrap it with the concept of love. And there's this book called Never Enough, and Judith Grisel is a neuroscientist, and she has been in recovery for 30 years from alcohol, marijuana, cocaine, meth, acid, all kinds of things. And so she wrote this brilliant doctory style book on all the different drugs and what they do to your body. But here's what fascinates me, and I'm going to go out on a limb and say I think it does Carli too, because that's what we're all about, is love and families and all that. But here's what Dr. Grisel wrote at the end of her book. It seems profoundly significant that the material change began when my father inexplicably changed course and took me out for my 23rd birthday. Friends' deaths, evictions, physical withdrawal, and a myriad of other tragedies weren't enough to propel me to change. Instead, it was human love and connection. The willingness to be seen with me and to treat me with kindness split open my defensive shell of rationalizations and justifications. It broke open the lonely heart that neither of us knew I still had.
No?
No questions?
Comments? You can
I have a
comment.
question.
Go ahead.
It's kind of a two-parter. I don't know how I want to explain it, but I guess one, what is like the longest length of time that you've had from a child's addiction beginning to when you actually saw the parents? And I guess the follow-up to that is do you ever think there's a point of no return where there's been so much damage
I'm going to answer the second one
in the
first.
families before you think that the parents will get it of how they can be supportive?
Okay, I'm gonna, that one is kind of in your area,
Sure.
but I want to say one thing is that as long as someone is alive, there's hope. Like, that when someone is still alive, there's always hope. So, so your question was, the time from when someone's a child.
No, from like the point of so you have parents and then the child that's in addiction. What's the longest amount of time that you've seen between when the parents are made aware of it and when they actually come to you? I guess I'll say my personal experience, I'm almost 19 months clean myself. I'm a social worker. I've been a social worker my whole life.
Oh, good for you.
But I feel like I've had to grieve the loss of my parents because I can't get them on the same page as me.
Yes. And there are so many families where we have that multi-generational situation going on. And to have sobriety and have life sometimes means we have to set boundaries and limits on our own family. And that's nothing short of ripping your heart out.
Which we can feel your pain, Lisa, from through the screen.
Yeah, that's hard. And I gotta say, Well, your own healing's going to take, you know, a lot of time with your own sweet little brain there. And then, you know, making sure you're in touch with good support. And then, you know, seeing where family is at. And there are some really creative ways that you can be with family, with boundaries and limits, where you at least keep in touch with them, and eventually they may come to see what's going on. But it can be months and years with family members, you know, finally seeing. And then sometimes there are people that don't ever see. And there
I
are,
feel like that's where I'm at with mine.
okay.
They're very stuck in their ways, and
Yeah.
it's just been an ongoing cycle of blame and opinions of
Yep.
every move I make is judged and criticized, and I'm continuously being told I'm still not doing enough. And I think being sober is enough, at least for a big chunk of my
Being sober
recovery.
It's huge.
is a huge accomplishment.
Yeah.
And I'm back to social work.
Yeah.
Yay, good
So-
for you.
Aw.
I
With
just-
all your experience, you're going to help so many other people with your personal experience in that. You know, I read a quote the other day, and so I screenshotted it, sent it to the printer, which is an old school way of keeping track of my notes. But it said that addiction and maybe the only disease that lacks sympathy, and of course that's what we're promoting in our talks and everywhere we go, is compassion. And so it's a lack of understanding and a lack of education. And Lisa, I suspect that may be somewhat underlying, you know, the perception that this isn't a disease, that you somehow made a choice. And sadly, that's a pretty common reaction. Thank you for asking that, Lisa. That was very courageous to share your
Thanks.
sobriety and accomplishment.
You mentioned that words can kind of cut like a knife. Like, you know, you got to be very careful and considerate of those in recovery. But what is kind of the best way to refer to somebody that might be in recovery? Do you say just that? Or, I mean, you want to avoid buzzwords like, you know, they're addicted or they're a recovering addict, or what is the best way to refer to them so that you're not, you know, cutting them?
So I'll give my personal experience, but again, Carli's our expert in that. You know, if I could change anything about my business, is that Carli would be like 30 years younger and running this whole place. I'm lucky we got her after her retirement, but oh my gosh, there's not many things I would change, but that's one of them. So I refer to very close family members that I have who are, you know, chronic progressed disease state, and I will say they're in long-term recovery.
Okay.
And so the long-term part, I don't know, it seems to settle people in, you know, recovery, which feels so active, recovering from. But if I use the word, you know, long-term recovery, people seem to be much more accepting of that now even than a few years ago. But Carli,
Well, the other thing is, are you asking when you introduce someone, what would you say? Or because sometimes the story isn't ours to tell as
Okay.
family members, you know,
Okay.
and addictive disease is one aspect of a whole marvelous creative person. It's just like this much, you know, it's just a little piece of the chocolate cake.
yeah, let's see, how can we, is that chat? So, you know, is there any more context? Like, is this, when someone's in with their peers, when someone goes to a 12-step meeting or an alumni meeting, it's already a given, right? So then you're not introducing or talking about something that other people may find frightening or unfamiliar to talk about. And I think that's what you're getting at, is when someone finds out someone is in long-term recovery, it can cause some discomfort on the other side. And so how do we bridge that? Is that kind of...
I attended one other webinar with people who are recovering alcoholics, and this came up with them too. That group too is, I think that if you're not in recovery, if you're not fighting a substance misuse issue, you lose sight that you got to, it's very sensitive. You got to be, careful how you say things. And I think that's a lot of people don't understand that. You got to be,
Yes.
be passionate. And if it does come up in conversation, choose words that aren't going to further wound this person, and
Exactly.
so.
I think I see a little hand up, Lisa. Is that right?
Yeah, I was just going to ask if I could chime in.
I said I want to ask Lisa, but I didn't want to put you on the spot. But thank you for putting your hand up.
So the best way to explain it is it's clear as mud. It's a lot like how the LGBTQ community is kind of treated. Like, what do you call a person that identifies as, a member of that community? Is it they? Is it he? Is it she? And really, I like, if you go to a meeting, if you go to an NA meeting or you go to an AA meeting, when we begin to talk, we say, "Hi, my name is Lisa, and I am such and such." And that's changed for me a couple times. It was, "Hi, my name is Lisa, and I'm a grateful addict." And then now, as I introduce myself, I say, "Hi, my name is Lisa, and I'm a woman in recovery." When you're in the community and you're at these meetings, I feel like you're right. It's a given. And we all have our own personal way of introducing ourselves. But that is a way that those who are not in the meetings don't quite understand. And truth be told, I still identify as an addict because I fight my fight every day. But I win my fight every day.
Yes,
And
you do.
so I don't get ashamed or embarrassed anymore. I recover as loud as possible because there's so many people that are out there that don't recover. So I don't know where everybody else is at, but City of Lansing, we had 5 overdoses in 50 hours just last week.
Oh, yeah.
From a bad batch. And one of them was my grandson's great-grandmother.
Oh, I'm sorry.
69 years old. So again, it resonated a lot when you said, this disease doesn't pick
Right,
this
it doesn't
person,
discriminate.
it picks everybody there. So I suggest asking the person you're talking to, just, and especially if you're introducing, glorify their recovery instead of glorifying their addiction. So, glorify, for me, I'd say, she's celebrating 19 months clean and serene, welcome Lisa Daberstein, da, 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 focus on that part of who they are instead of the addiction part of who they are, because we want to be known for how hard we fight and how much we care about making progress in the knowledge of addiction and how we treat it.
Look at this comment that just came up. Lisa, I love that perspective to recover out loud. That's awesome.
Thank you, everybody, for being here today. Carli and Rae, always appreciate your expertise. All right, everyone, I'll have a wonderful rest of your day. Please take good care. All right.
Okay.
Till next time.
Thank you.
Bye.
Thank you,
Thank you.
folks. Thank you for coming.